Welcome, everyone, to episode 3 of the TIMI Talks podcast. This is David Berg, here with my good friend, colleague, and co-host, Nick Marston. On today's show, we will be joined by one of my all-time favorite people, fellow critical care cardiologist and TIMI investigator, Dr. Erin Bohula, to discuss the recently published FREEDOM COVID trial. So before we bring Erin onto the show, Nick, how have you been?
I've been good, David. Thanks. It's been a busy March with some service consult time and travel for work, but I did still manage to catch a bit of March Madness. And with our two teams, Texas Longhorns and your Arizona Wildcats, being number 2 seeds in the tournament, that really set us up nicely for a friendly wager.
Oh, yeah, it did. My hometown Wildcats were in the tourney as a 2 seed, had a lot of promise. And I have to say, I love Tommy Lloyd. I think he's done amazing things for the program in just a couple of years. But a first round loss to Princeton was a tough pill to swallow. I think they even lost before we could even confirm our lunch bet.
They did. In your defense, you were attending in the CCU, so more important issues. But I still think we have to count it. I made the mistake of starting to text my college friends about Final Four tickets when the Longhorns were up big during the second half against Miami. That obviously didn't end so well. So I think at this point, I'm going to be rooting for the number 9 seed, Florida Atlantic, to win it all. They'd be the lowest seed ever, actually, to win the national championship.
Yeah, I mean, what a great Cinderella story. I think I'm with you. They're my team for the Final Four as well. But I feel like we might be morphing into a sports podcast. Are we?
Oh man, I don't think I have the time to keep up with sports 12 months a year. But I'll take this as my cue to transition from the basketball court to the Supreme Court for our next, much more relevant topic of discussion.
Nice. I like that. There it is.
It's not very often that cardiology is being discussed within the walls of the United States Supreme Court, but that's exactly what happened this week. And so with the Supreme Court hearing arguments on the Amgen versus Sanofi case, I think this is worth discussing, not just because it relates to my favorite class of drugs, the PCSK9 inhibitors, but also because the decision could have broad implications on drug development, innovation, and the therapeutic options that are available to our patients down the line.
Yeah, no, totally. I think that there's, I think that it's actually a really nice sort of case example of a lot of things that we talk about all the time. So you probably saw there was that article in JAMA this week.
Yep.
Did you catch that?
I did. And I was really fascinated by it. It nicely summarized the issues. And so I want to give a little background here. Historically, monoclonal antibodies were primarily just used for kind of research purposes as diagnostic tools. So nobody really paid much attention to the broad patent labels that actually provided exclusivity not just to the specific antibody structure, but for all antibodies targeting a given antigen. And so it was really quite a broad patent. However, with the increase in therapeutic uses for monoclonal antibodies, in fact, I think last year they cited 30% of drugs approved were monoclonals. The U.S. Patent and Trademark Office reversed this broad patent rule back in 2018 to prevent a single patent from covering as much as an entire antigen.
Wow.
And the reason PCSK9 is at the center of this discussion now is because evolocumab falls kind of somewhere in between covering the patent for it falls somewhere in between covering an entire antigen and just the structure of the antibody. So the patent actually covers the epitope to which the antibody can bind. And so this prevents other companies from creating a completely different antibody structure, but with the same binding site. And so the argument that's being discussed in this case is that evolocumab's competitor, alirocumab, while being a different antibody structure, does bind to the same target as evolocumab, although at a slightly different location. And so to date, the federal courts have upheld the narrower view of the patent law, which again only provides protection to the antibody structure itself. However, this case has now made its way all the way up to the Supreme Court, being heard this week, and so we'll have to see what they decide.
Interesting. So I guess what are the implications for us as cardiologists, or I guess maybe clinicians more broadly, and for our patients?
Yeah, it's a good question. If the Supreme Court reverses the Federal Circuit decision and rules in favor of a broader patent law, this could once again become the norm. The authors of the JAMA piece this week suggest that this could reduce competition, innovation, and patient choice. However, from the standpoint of the drug makers, a reversal would help to uphold their intellectual property and offset some of the risk associated with these very large, expensive investments in new drugs.
Fascinating. Yeah, I mean, I guess I can certainly appreciate that tension that, pharmaceutical companies, of course, want to protect their intellectual property as much as possible. But as you said, there's a trade-off there. And we certainly know that competition is an important driver of innovation in general and in drug discovery. Well, so thanks for that tidbit. I think that we'll more to come on that front, certainly as we hear what the Supreme Court has to say. But switching gears again, I'm excited to bring on our discussant today. As I mentioned, it's Dr. Erin Bohula to discuss a topic that she and I really have thought a lot about over the last several years, which is optimal anticoagulation strategies or antithrombotic strategies in hospitalized patients with COVID-19. And like many clinicians and researchers, we took a little bit of a detour from our usual activities during the pandemic, as everybody did, really to try to help build the evidence base for managing patients with COVID-19. And along with Dr. Dave Morrow and the Critical Care Cardiology Trials Network, or C3TN, we designed and executed the COVID-PACT trial, which was an antithrombotic strategy trial in critically ill patients with COVID-19. And I emphasize critically ill because that ends up being an important distinction that we'll talk a little bit more about with Erin. So today we'll be discussing the FREEDOM COVID trial, which was a study of prophylactic anticoagulation intensity in hospitalized non-critically ill patients with COVID-19. And that study was just presented a couple weeks ago at the American College of Cardiology Scientific Sessions by Dr. Valentin Fuster and simultaneously published in the Journal of the American College of Cardiology. So let's go ahead and bring Erin on the show. Welcome to the podcast, Erin. It's great to have you here.
Thanks so much. I'm thrilled to be able to join you too, David and Nick, and thanks for having me.
It really is great to have you join us, Erin, and we want to start off with a huge congratulations on the new addition to your family. I know everyone here at TIMI is very excited for you guys.
Yeah, thanks, Nick. Yeah, we recently welcomed our amazing third son, Cooper, to our family, and he's just the sweetest, happiest little guy, and his two older brothers couldn't be prouder.
I'm sure it, but three boys, right? I guess I'm going to go with the poker analogy on this one and assume that three of a kind is a strong hand, rather than the baseball analogy of three strikes and I guess the end of that.
Yeah, no, it's true. I have to say I'm officially a boy mom at this point. And I think I've realized that means that I have to be pretty comfortable with a certain level of chaos at all times. And I'd say that maybe a sad but true example as well. Well, you two were at ACC, and actually, fortunately for this, I was still out on maternity leave. I ended up sitting with one of my sons in the ER while he got stitches on his face.
Oh no!
Yeah, for the third time in his life.
Oh my gosh.
So I don't know. Anyway, it made me think of, as you're saying, three boys and three strikes and three of a kind. That maybe the saying of all good things come in threes is generally true in my case, but maybe with few exceptions like that one.
Yes, hopefully that wasn't the newborn.
No, that was my 10-year-old.
Yeah. Well, of course, we shamelessly asked you to join the podcast after just 2 days of being back from maternity leave. So I'm sure you have a lot of catching up to do. So let's dive right in. I can't think of a better discussant for this important topic.
Yeah, no, I couldn't agree more. And Erin, it's funny, as I was thinking about this discussion today, I was reminded of those early days of the pandemic, and I can't believe it's been 3 years since those early days. And if you remember, the cardiovascular building at the Brigham was completely transformed into just like one giant ICU to care for all of the COVID patients that were coming in at that time. And you may remember we were actually paired together right at the beginning and rounding in our CICU together, and it was crazy overcapped. I mean, we were sort of jamming patients in any place that we could find them. But that is sort of a lasting image for me that I think I'll carry with me the rest of my career.
Yeah, no, me too. I have to say, I had the same sort of thought and kind of reminiscing when we were sort of coming into today's discussion. And I mean, what a treat it was to be able to work with you in that setting. You know, despite that incredibly surreal period that we were in. So, yeah, it's very powerful memories from that time for sure.
And in those very early days, really right from the get-go, we started hearing reports from China and Italy about the high risk of thrombotic complications in patients with COVID-19. And that, of course, led to multiple clinical trials assessing the benefit of both anticoagulants and antiplatelet agents in patients with COVID-19. And really, the primary results have been quite varied. And so, Erin, I was wondering if you might set the stage a little bit by talking about some of the key studies that have influenced clinical practice guidelines to date.
Yeah, sure. Of course, Nick, be happy to. But maybe before I dive into the key studies, I also wanted to reflect on those early days. Really before we knew anything about COVID-19, and when information was really mostly being disseminated through direct conversations with providers rather than publications. I participated in a podcast where we, repeatedly spoke with a few Italian ICU physicians who, and that was, in the heat of that first horrible wave of COVID-19 that hit northern Italy. And anecdotally, they had the impression that patients were frequently and dramatically succumbing to thrombotic complications with COVID-19. And so the question of how to manage these thrombotic complications was very much at the forefront for myself and for many others, which is, of course, what prompted several groups to address this question through, design and then performance of rigorous randomized control trials. And so I guess in that context, I'll move on to describe one of those key studies, the multi-platform trial. It was a large international trial that randomized more than 3,000 hospitalized patients with COVID-19, and that included both critically ill COVID-19 patients and non-critically ill patients. They randomized those patients to either full dose anticoagulation or what they called usual care, which could include your standard dose prophylactic anticoagulation or an intermediate dosing of prophylactic anticoagulation. Importantly, their primary endpoint was the amount of time alive and free of organ support. And organ support they defined as requiring mechanical ventilation, non-invasive positive pressure ventilation, high-flow nasal cannula, or vasopressors or MCS like ECMO. And it's worth making two important points about this endpoint. First, the organ support component, I think, is really based on the hypothesis that COVID-19 respiratory illness progression might be a result of sort of microthrombotic events that occur in the lungs. And then that phenomenon you'd think might actually be then modified by the addition of anticoagulation. So that's one point. And I think the second is just that the multi-platform primary endpoint did not include macrothrombotic events. So things like PE, DVT, MI. So what the multi-platform investigators found was that they saw a convincing benefit for organ support endpoint with full dose anticoagulation in the hospitalized patients with COVID-19 outside of the ICU, so the non-critically ill patients. But that same benefit was surprisingly not seen in the higher risk patients, so those requiring critical care. And in fact, there was even a question raised of potential harm in this critically ill population. Also worth noting that there was a suggestion of a reduction in macrothrombotic events in both populations, although this was not formally tested as a part of the multi-platform trial.
No, thanks, Erin. I mean, I think that was a great summary. And I think just to pick up on your last comment, I think for many of us, the multi-platform trial was an incredibly important study. But it also raised a number of questions. And in particular, it struck me that the choice of an organ failure endpoint, as you said, rather than a thrombotic endpoint, led to some uncertainty about sort of optimal thromboprophylaxis strategies, particularly in the critically ill patients with COVID-19, since that's the group where we really see very high rates of arterial and venous thrombotic complications. And so that's a nice segue, I think, to talk a little bit about the COVID-PACT trial, which was led by our group and coordinated by the Critical Care Cardiology's Trials Network. And Erin is the lead author on that study. Perhaps you could tell us a little bit about COVID-PACT and specifically the study design and primary results.
Yeah, of course. Yeah, okay, so COVID-PACT was a 2-by-2 factorial randomized controlled trial focused on critically ill patients with COVID-19. We conducted the trial at 34 sites across the US and ultimately randomized 390 patients who required ICU level of care. And they were randomized to either full dose anticoagulation strategy or standard dose prophylactic anticoagulation. And in those patients who did not have another indication for antiplatelet therapy, like a recent ACS event, those patients were then eligible for an additional randomization to either clopidogrel, so an antiplatelet agent, or no antiplatelet therapy. And the primary endpoint of the COVID-PACT trial was a composite of venous and arterial clotting complications, which included PE and DVT, and that was assessed through hospital discharge or 28 days. And so I think notably this endpoint was not focused on organ support as the multi-platform trial was, but rather on macrothrombotic events in critically ill patients. And the results that you so eloquently presented at the hotline session this past fall at ESC, David, were that the treatment of critically ill patients with COVID-19 with full dose anticoagulation as compared to standard dose prophylactic anticoagulation lowered the risk of developing venous and arterial clotting complications by 44%. There was also a non-significant numeric increase in life-threatening bleeding. The rates were pretty low, 2.1% versus 0.5%. But there were fortunately no fatal bleeding events in the trial and no excess in mortality. And as I mentioned, this was 2-by-2 factorial design. And so we also tested the question of whether there was benefit for antiplatelet therapy. And what we found was that there was no difference in the risk of clotting complications or bleeding events in patients treated with clopidogrel as compared to no antiplatelet therapy.
Well, thanks, Erin, for summarizing that, and congrats to both you and Dave Morrow and the team on such a incredible trial. It's a ton of work to do an investigator-initiated trial during a global pandemic, and really, really impressive results. And so, I think that brings us to the FREEDOM COVID trial, which was just presented at ACC in New Orleans. And in contrast to COVID-PACT, FREEDOM COVID focused on the non-critically ill patients hospitalized with COVID-19 and randomized them to one of three strategies. The first was standard dose prophylaxis with enoxaparin. The second was a full dose anticoagulation with enoxaparin, 1 milligram per kilogram every 12 hours. And then the third arm was a full dose anticoagulation with apixaban, 5 milligrams BID with standard dose reduction. And the primary endpoint or outcome of this was a 30-day composite of all-cause mortality, requirement for ICU level of care, systemic thromboembolism, or ischemic stroke. And I'll point out that for the primary analysis, the two full dose anticoagulation arms were combined and then compared against the standard dose prophylactic anticoagulation arm. So Erin, do you want to walk us through the results of this trial?
Of course, happy to. So just to again highlight the primary endpoint of the FREEDOM COVID trial, which you've just outlined, which was a composite of all-cause mortality, need for ICU level of care, which were all the components that went into the multi-platform trial, the organ support endpoint, and then thrombotic events. And this was assessed at 30 days. And so this endpoint was really a combination of the endpoints that were used in the multi-platform trial, so included organ support, and then also in the COVID-PACT trial that looked at thrombotic events. And what they found was that this primary endpoint occurred in 13.2% on the standard dose prophylactic anticoagulation and 11.3% in those on full dose anticoagulation. Again, that grouped assessment of the two arms with full dose anticoagulation. And the hazard ratio was non-significant at 0.85 with a p-value of 0.11. So important to note, this was a neutral result for the primary endpoint. Notably, the rate of thrombotic events was very low in this study and therefore really underpowered to assess for a difference in this non-critically ill population. And so also as a result, the endpoint was dominantly comprised of the elements, the components of death or the need for ICU events. And so with the caveat that the primary endpoint was neutral. If we were to look at the composite of death and need for mechanical ventilation, that was significantly reduced with a hazard ratio of 0.77 and a p-value of 0.03. And the same was true for each of those individual components of death and mechanical ventilation. They had very similar hazard ratios. And so, although this is, of course, hypothesis generating, since the primary result was neutral, it does certainly raise the question of whether full dose anticoagulation might actually prevent progression of respiratory disease in patients with COVID-19 in that early phase, i.e. those who are hospitalized but not critically ill. And I would say that generally speaking, this is fairly consistent with the results that we discussed earlier around the multi-platform trial.
Well, thanks, Erin. That's a really, really great summary, and the results are quite intriguing. Do you think that these results then bring us closer to the truth of answering this question?
Yeah, I mean, I guess the way I'm sort of interpreting it right now, or understanding the data, is I think the multi-platform trial suggests that anticoagulation, as I mentioned, might reduce the progression of respiratory failure in non-critically ill patients, and also hinted at a possible benefit for thrombotic events in both critically ill and non-critically ill populations. And we discussed that COVID-PACT showed a benefit for prevention of thrombotic events in that critically ill population. And then FREEDOM COVID, again, suggested a benefit, albeit with a neutral primary result, on a benefit for prevention of progression of this respiratory disease, again, in a non-critically ill population. But again, they didn't really have the power to address the question of thrombotic events. And while we haven't discussed this yet, but of course, in all the trials, while the bleeding rates were generally low, not surprisingly, we saw that higher intensity anticoagulation likely comes at the cost of more bleeding. And so I would say, sort of in summary, it seems as if there is a rationale for consideration of higher intensity prophylactic anticoagulation in hospitalized patients with COVID-19, but recognizing that the specific benefit may vary depending on the population in question.
I think that was incredibly well summarized. And if I may, I might just sort of point out a couple of things that kind of were embedded in the things that you just said. So one is, I think you're absolutely right. It's important to acknowledge that in the setting of a neutral primary result, that the effect of an intervention on secondary endpoints really should be viewed as hypothesis generating. That's sort of, clinical trials 101. But I do have to say that, with that caveat, I tend to agree with you that I do think that there's a potentially compelling parallel between, the results of FREEDOM COVID and the non-critically ill multi-platform trial results, which is, that perhaps that there is an effect of full dose anticoagulation on risk of progression to respiratory failure in those patients who are hospitalized but not critically ill. So if you kind of catch that early enough, maybe, just maybe, that has something to do with sort of the effect of anticoagulation on risk of pulmonary microthrombosis, to sort of bring us back to that hypothesis that you raised at the beginning. And then I think on the other end of the spectrum of illness severity, it seems that full dose anticoagulation doesn't really appear to decrease the risk of disease progression in critically ill patients with COVID-19. But I do think that the totality of the evidence suggests that it does appear to meaningfully decrease the risk of venous thromboembolism, which is obviously an important complication in that group. So it may be the case, just as you said, that the clinical benefit of full dose anticoagulation is different in critically ill and non-critically ill patients.
Yeah, so well said. I think it's complicated, but I do think that these trials are probably complementary and do get us closer to maybe the truth, as Nick asked.
Yeah, and I think, from a trial design perspective, if I can sort of insert that, I do think that there's an important lesson here, which is that, when you're picking a primary endpoint, it's so important to think not only about whether this is a meaningful endpoint, but also is this something that's modifiable by the intervention in the particular population being studied. And sometimes you have sort of knowledge or confidence in what that may be, and sometimes you're talking about a disease that you is totally new. And so it's a little bit harder to predict what is going to be the endpoint that's going to be modified by the intervention. But that notion of picking something that's both meaningful and modifiable, I think, is important.
Yeah, no, I 100% agree. And I think, as you said, this was a case with COVID-19 where I think we were, sort of flying blind a little bit in terms of, what might be the modifiable endpoint. And I think it was a leap, an understandable leap based on, some of the pathology reports about the organ support endpoint. But anyway, I think that's a really important point about, identifying the correct endpoint. And certainly, that is the holy grail in clinical trial design, isn't it? I feel like we talk about this all the time here about identifying the right intervention for the right patients and then for the right outcome, right? So it's critically important.
Well, this has been a really terrific discussion on a topic that has consumed so much of our lives the last 3 years. We're so grateful for your time today, Erin. It's so nice to have you back in the office. We've all missed having you here, and I look forward to catching up with you in the days to come. So thanks again.
Thanks so much for having me.
This is Nick and David from the TIMI Talks podcast, signing off.
Thanks for listening. The TIMI Talks podcast is hosted by Dr. David Berg and Dr. Nick Marston and produced by Kate Brennan. Like and follow us on Apple Podcasts, Spotify, and Google Podcasts, and follow us on Twitter @TIMI Study Group to be informed about upcoming episodes.